I'm so pleased. Hi, wave. There we go. Kate Lowe is a civil rights attorney who, let me move this up. Who primarily represents incarcerated people in cases about their conditions of confinement. She's passionate about defending the constitutional rights of people who are in jails and prisons. This includes challenging the practices of disrupting or discontinuing medication for opioid use disorder upon incarceration and failing to provide treatment that comports with community standards of care to people in jails and prisons. She practices law at the law office of Ryan J. Villa. And I am just thrilled to have Kate here because she brings a real important social justice lens to what we do. Kate.
Thanks so much, Dr. Page. Thank you for having me. Yep, that is what I do. I'm a civil rights lawyer. And one of the things that I became most impassioned about over the last 5 years or so is access to treatment for opioid use disorder and substance use. And that's because in all my work, what's very critical is to be client-centered. My clients know what's up. They tell me what I need to be paying attention to. And it really became obvious that access to Suboxone and methadone was critical for people coming into facilities and people in incarceration in prisons as well. So first, I just want to make a note about language. The language around this is always evolving. I can never catch up. And so I want to acknowledge that up front. When I started working on this not very long ago, medication for addiction treatment is the language we use the most. Now, I think medication, when it comes to methadone, Suboxone, and naltrexone, we use medication for opioid use disorder. But also I want to acknowledge like the history of medicalization and how, you know, it's important that we think about that and challenge that in particular, and challenge that and discuss it. Within the context of law, we sometimes have certain legal standards which carry with it certain language. And so while we try to have evolving standards of decency and evolve the language along with it, if you hear me talking about chronic conditions and diseases and disability, it's likely because it's part of a legal standard I'm talking about. I started doing this work when I was out at MDC and I was on, which is our local detention center, and I was out on one of the withdrawal pods, and there was somebody who was in really obvious distress. He was laying under a blanket and moaning and shaking, and I went over to him and I asked if he was okay and if there was anything he wanted to talk to me about. And he said he was withdrawing from Suboxone, and he described the symptoms he was having. So I went up to the pod officer and said, "Hey, could you call medical for that guy? He's like clearly not in great shape." And it's the only time in all the time I spend out of the jail that somebody lost consciousness in front of me. And I realized the only reason he was in the withdrawal pod, as far as I knew, was that he was withdrawing from Suboxone. I don't know if his medical crisis had anything to do with that withdrawal, but it was clear that he was suffering, and it was clear that he wasn't receiving his like essential doctor prescribed medication. And so from that point on, I started to really do a deep dive into opioid use disorder and treatment in settings of incarceration. And so what I aim to do today is to give you all a quick and dirty overview of some of the national and local happenings and legal standards around that. So with that, I'm going to pull up a PowerPoint. And also just to go back to say, I started to really understand that people who were in treatment, who were on methadone or Suboxone, who had that prescribed to them and were coming into incarceration, were going through like not detox in like a super, detox sounds to the layperson like, you're being detoxed. It's a medical process that's happening. But really understanding that people were being forced to withdraw and experiencing the suffering that came with that forced withdrawal, both the physical and psychological, but it was placing them in danger during their incarceration. It was placing them in physical danger as drugs are widely available in facilities, So there's a risk of relapse, overdose, and death. And then also an increased risk of suicide, particularly for people withdrawing from opioids. So the drugs are there in the jails and prisons. And I need to share my screen with you. And I beg your patience. So since 2001, overdose deaths in state prisons have increased 600% and 200% in county jails. This was a statistic that kind of blew my mind. It came out in fall of this year. I'm happy to share the links to the articles afterwards. In September 2021, the Albuquerque Journal reported that 200 fentanyl pills were confiscated from just one person who was at MDC. And in my experience, Suboxone as a contraband is a constant at MDC and in the Department of Corrections, and I would assume other correctional facilities as well. I believe the Department of Corrections has stopped the practice of posting their Suboxone seizures on Twitter, but for a while, there were fairly regular updates about the Suboxone that had been seized in facilities. Some of it came in through the mail, and as some of you may have seen recently, the Department of Corrections as of today, is using a vendor in Florida to receive all personal mail for inmates so that that vendor in Florida can check it for contraband to prevent contraband from coming into the facilities. This kind of blows my mind in some respects because I think it really hurts our community. It breaks ties between family members, and it doesn't actually hit the root of the problem. So if there's a lot of contraband coming in through the mail, and I don't know the stats around that, I need to do some IPRAing, it would seem to make as much sense to me as to try to provide treatment for opioid use disorder in the facilities, which would then, ideally reduce the Suboxone coming in and make the places safer. So, and that doesn't happen at the Department of Corrections. So nationally, there's a bunch of different things happening. There's legislation in New Hampshire and New York and a couple other areas that require correctional facilities to screen and provide evidence-based treatment, including methadone, buprenorphine, or naltrexone. The US Department of Justice under the Trump administration investigated Massachusetts prisons for violating the American with Disabilities Act for failing to continue people on their doctor-prescribed essential medications. And also, I believe under the last administration, the Department of Justice investigated the Cumberland Jail in New Jersey for civil rights violations for failing to provide MOUD, both for treating withdrawal and for people who were current on it, and found a connection between an increased risk of suicide at that facility and failure to provide this medication. The Department of Justice found that it violated there was probable cause to believe it violated the 8th and the 14th Amendments. I know I'm probably talking fast, so if anybody wants me to slow down and talk about something more, Dr. Page and Christina, please, let me know. Or if I should move along, also let me know. There's litigation around the country, and then, there's lots of associations calling for the provision of MOUD in jails and prisons, including, the National Sheriff's Association, tons of medical organizations that I'm sure Dr. Huerta can address. And recently, I believe last fall, Georgetown Law provided a publication on the national snapshot of access to MOUD in jails and prisons. Warning in there, it says New Mexico is fantastic and that we have a bill in place, we have legislation in place to provide MOUD in jails and prisons, but as some of you may have experienced, people get New Mexico confused with all kinds of different things. And the link is actually to the New Hampshire law. New Mexico does not have such a bill. So when you read it and you get excited, as lots of people did and emailed me about it, it's not a thing yet, but we could all make it a thing. In New York this year, the governor signed into legislation several different pieces of legislation. One established a program for MOUD for incarcerated folks. And in doing so, she gave a press conference and talked about recognizing that doing so lessens the likelihood of overdose upon reentry. I think that the The last information I had is that the state prisons there are preparing to gear up to provide treatment to thousands of people in the next year. The legislation also decriminalized the possession and sale of needles and syringes, and explicitly recognized that this was to reduce the rate of hepatitis C and HIV and other bloodborne illnesses. In New Hampshire, where they do have the law, not New Mexico, it's in their code about corrections. There they discuss wardens as superintendents, and they require that all superintendents screen and provide MAT for folks where it's appropriate, regardless of whether that person was on MAT when they came into the facility. So it's not just about continuing people on their essential doctor prescribed medication, but it's identifying people with OUD, and if they want it, providing MAT. And critical, I think, to any legislation is not limiting it to any one modality. New Hampshire requires it be any of the FDA treatments, and I am not a doctor, so I will not talk about how those decisions about treatment are made. Here are two faces you don't usually see agreeing with each other. Both the Trump and the Biden administration have made alterations to the CFR around prescriptive powers, and specifically around taking away some of the barriers for prescribing buprenorphine. I am not an expert in the X waiver, but what I do know is that it has made it so there is some registration process, but you no longer, if you're a mid-level provider or an MD, don't have to go through the whole X waiver process to have a certain number of Suboxone prescriptions out. So Suboxone, for those of you who aren't super familiar with all these modalities, Suboxone is the medication that I'll let the doctor address more, but it's the one that I can go down to Walgreens right now if somebody prescribed to me and pick up. It's so this was about having a low barrier to this care directly as a result of wanting to address the opioid epidemic and reduce the number of people who are overdosing and dying. And so Suboxone can now be prescribed, much more easily than it could even 2 years ago, which was still only required an X waiver at the time, which always brings me to the question of why isn't it happening more all over New Mexico? We have a high rate of opioid use. We have since before the epidemic. It continues. The Albuquerque Journal just ran articles a couple of weeks ago about the rise of fentanyl and how dangerous it is. In 2018 or 19, the Legislative Finance Committee for the state found that 1/3 of people incarcerated in the New Mexico Department of Corrections were there for a probation violation, either missing an appointment or a failed drug test. So why isn't this treatment happening more? Maybe we can figure it out together. In New Mexico, we do have good things happening. At the Bernalillo County Metropolitan Detention Center, Recovery Services provides both methadone and Suboxone. Methadone, there's methadone continuity and inductions, and there are some limitations. And Suboxone is currently maintenance, but my understanding is that inductions are in the works. I am not the person with lots of information on that. Being able to continue your methadone in incarceration is critical for so many reasons. Some folks at MDC report to me that they have discontinuity of medication so that they go several days without their methadone upon intake. And I think, there are kinks to be worked out in the system. There are some limitations on who can be in the program. I don't know if they've changed recently, but if you have out of county court, you don't get continued on your methadone. There are adverse events. I know staffing is sometimes an issue for inductions. And then something folks have been reporting to me over the last year is that they haven't been able to prove opioid use for a period of 12 months. The Association of Counties reported that Doña Ana County Detention Center provides maintenance. In the Department of Corrections, pregnant people receive care through Milagro, and some nursing people can continue care. And for nursing people, there, I don't know all the ins and outs, but I know that there are folks who are, for instance, housed at the Metropolitan Detention Center and are current on their methadone, nursing or otherwise. So say you're somebody at MDC, you came in on your methadone, you're current on your methadone, you're doing great on your methadone, you get sentenced to the Department of Corrections, you have to withdraw from your methadone, often prior to going to the Department of Corrections. The Legislative Finance Committee found that there's insufficient access to effective treatment in jails and prisons, to evidence-based diversion programs, and that helps perpetuate the cycles of substance abuse and incarceration. There's a super cool law in New Mexico about breastfeeding and lactation, which requires every correctional center to have policies about continuing medication-assisted treatment for lactating people. When we're thinking about cases and doing cases, there's certain legal frameworks we think in. There's the American with Disabilities Act, which says that no qualified individual with a disability shall, by reasons of such disability, be excluded from participation in or denied the benefits of services, programs, or activities of a public entity, or be subject to discrimination. So cases argue that jails and prisons are a public entity. There's no question about that. Medical care is a service of the public entity. Also really no question about that. And then the argument is, if you come into jail on MOUD to treat your OUD, are you being denied benefit because of disability? Thanks, Christina. Courts have found, and then the other framework is the Constitution prohibits cruel and unusual punishment. These cases, you have to show deliberate indifference to a serious medical need. And so that's where we talk about, OUD being a serious and obvious medical condition that needs to be treated. Those cases usually come in the form of preliminary injunctions, where someone's outside of incarceration, is going to be incarcerated, and knows that they're not going to have their treatment. So they sue to make sure their treatment's not disrupted. To do that, they have to show irreparable harm. This comes with a lot of educating of judges about OUD, that OUD is a chronic condition, and this takes needing, you should have a medical expert involved, you should have the person's treating physician. And there's a lot of education about how treating withdrawal is not treating OUD. I'm going to fly through these cases, but in 2018, the first case came down out of Massachusetts, where the court found that there would be irreparable harm to the plaintiff who was on methadone, and it would violate both the ADA. It would more likely than not violate the ADA and the 8th Amendment if this person was deprived their methadone. And so they granted an injunction. An injunction is saying you have to give them this medication. If you can see that the court really adopted the facts that the plaintiff put in front of them in terms of the education. Smith was one of the next cases in 2019. It was based on the ADA and found that, by having a practice of not providing Suboxone based on no medical reason was enough of an inference to find that the defendants, being the corrections department there, denied the plaintiff's request for Suboxone based specifically on her disability. Most recently, in October 2021, PG versus Jefferson County, the court found that to deny this person their methadone treatment would violate the ADA and the 14th Amendment. And the defendants in most of these cases argue that there's no constitutional right to methadone, and that there's medications that can manage symptoms of withdrawal in a way that meets constitutional standard. And the court there rejected it and said, treating withdrawal is not the same. There's this very big bummer of a law called the Prison Litigation Reform Act. It makes it really, really hard to sue for people who are incarcerated. You have to exhaust your administrative remedies. This is out of New Mexico. This is another way that cases come to be. It's when something really, really bad happens. I mean no disrespect by giving short shrift to the really, really bad things that happened here. This was a woman in Santa Fe County who was not provided medication for opioid use disorder and wound up with an infection from when she was in jail and wound up dying. And there, the plaintiffs showed that Santa Fe County knew that OUD was a big deal, knew that, MAT was the standard of care, didn't provide it, and the court found that the plaintiff could continue with the lawsuit because there were enough facts to show that it was an unconstitutional custom by failing to treat detainees under the circumstances. There's lots of opportunities for advocacy. If you know somebody who's going into prison, or you are somebody who's going to prison, you should contact the facility ahead of time. I'm happy to talk more about this in Q&A, or you're welcome to contact me afterwards. And, you know, in the law, there's this idea of evolving standards of decency, and in medicine, there's the evolving standards of care. And this is our opportunity to really organize with each other, I think, to create a culture where it's unacceptable to deny people's constitutional rights, federal rights, and human rights, and to, you know, stop suffering. And with that, I pass it on to Dr. Huerta.
Thank you so much, Catherine. Kate, that was really, I mean, a lot of information in a short period of time, and really eye-opening. So we will have some time, I think, for Q&A, and I'm going to introduce Sergio Huerta. He's an associate professor at UNM, and he's board certified in internal medicine and addiction medicine. He also serves as the medical director of Recovery Services of New Mexico, the largest opioid treatment center in the state. The Recovery Services group pioneered jail-based medications for opioid use disorder in New Mexico and has provided treatment on site at the Bernalillo County Metropolitan Detention Center jail for over 10 years. Dr. Huerta is a strong advocate for helping address opioid use disorder in criminal justice populations and for expanding medication for people who have opioid use disorder who are incarcerated. I'm pleased to say that I'm able to work with Dr. Huerta, and he's a wonderful advocate. Thank you. Sergio, all yours.
Hi, thank you for that introduction. Good afternoon, everyone. Thank you for coming. And thanks, Catherine, for that great presentation as well. It's really a pleasure to be here. I have a very brief PowerPoint that I wanted to go through and really just discuss and kind of add on to her presentation about the current state of OUD treatment, specifically here in New Mexico. And then talk a little bit about Recovery Services journey and kind of the successes that we've had so far and kind of where we're going in the future when it comes to jail-based treatment for opioid use disorder. So let me go ahead and pull this up really quick. Can you all see that okay? All right. So, you know, looking at OUD in New Mexico, about 1 in 10 New Mexicans is actually living with a substance use disorder. And that equates to about 200,000 New Mexicans with that. And of those, what's really sad is only about 1/3 of them are on treatment. And this represents a really significant treatment gap when it comes to substance use disorders. And in fact, echoing what Catherine had said, in 2020, New Mexico actually had its highest drug overdose death rate ever recorded. About 800 people passed away from an overdose. And most of those people were untreated, and it was mostly related to fentanyl and methamphetamines. These statistics are actually even further magnified in incarcerated patients. So if you look at people suffering from incarceration, they're actually 10 to 40 times more likely to die of an opiate overdose when you compare them to the general population. And this figure is even more stunning because the United States has, you know, the second highest rate of incarceration in the world. And nearly 2/3 of people who are incarcerated are suffering with a history of substance use disorder. So it's a very common and unfortunate thing that's affecting people who are suffering from incarceration. If you look at New Mexico specifically, the number of inmates admitted to the prison system for drug possession specifically has increased by almost 20% in the past decade. And the three-year recidivism rate, which is actually when somebody's released from incarceration and returns back to incarceration after release, was 54%, so very high. And one of the main drivers for that is substance use disorders. As Catherine had mentioned, you know, legal issues related to that causing them to unfortunately go back to incarceration. Medication-assisted treatment, there's different words and vernaculars as was mentioned. Some of it can often be referred to as medications for opioid use disorder. For this presentation, we'll just call it MAT for short. It's really a proven way to help combat the opioid crisis. And the criminal justice system must be considered an additional entry point when it comes to the treatment for opiate use disorder. There are 3 medications that are associated for opiate use disorder that are FDA approved for that. And these include methadone. The second one is buprenorphine, sometimes called Suboxone when you're looking at the buprenorphine-naloxone combination, and naltrexone, which is sometimes called Vivitrol when it's an extended release formulation as well. And there's been proven benefits when it comes to expanding MAT, and it's really an important public health strategy. So there's multiple sources, multiple literature, multiple things that show that people who use MAT have reduced opioid usage, reduced risk of relapse, reduced risk of overdose and death, increased treatment retention, improved social functioning, and even a reduced risk of infectious disease transmission like HIV and hepatitis C. When you look here specifically, though, for patients who are suffering from incarceration and are offered jail-based MAT, you can also see these benefits as well. So people who are offered methadone during incarceration were more likely to engage in treatment post-release, had less likely to use opiates post-release, had reduced use of injection substance use post-release, and had reduced contraction of communicable diseases. So very similar, echoing to kind of the overall benefits of MAT in general. But even more importantly, I think the provision of MAT while somebody was incarcerated reduced the rate of fatal overdose by more than 60% in one study. And as was mentioned, there's a lot of support when it comes to providing jail-based MAT from medical societies, even from the National Sheriff's Association, which calls MAT the standard of care for the treatment of OUD. So the question is, despite all these proven benefits, why is there really no access to any of this? And there really is no access for any of this when it comes to providing MAT for patients suffering from incarceration. In fact, only 0.5% of all prisons and jails in the United States offered either methadone or buprenorphine. And only 14 states currently are offering methadone or buprenorphine as of 2018. And when you look at drug court programs, only about a half of them allow medications for opioid disorder as part of their treatment. So it's not really encouraged in some settings. So why is that? Well, there's unfortunately a lot of barriers when it comes to providing MAT for incarcerated populations. This is just a small sample of some of the things that have been provided in the literature and that we've experienced locally at Recovery Services in New Mexico. This is not an expansive list. But one of the things that comes up quite a bit is the cost and logistics of these programs. Who's responsible? Is it the facility? Is it the county, the state? Is insurance going to pay for this? The logistics of staffing, training, certification, storage, all those things when it comes to actually providing this medication in an incarcerated setting. Sometimes there can be concerns about security as well. So methadone, Suboxone, they are controlled substances. And when they're provided in a controlled environment like a jail or prison, there can sometimes be questions about diversion and storage of these medications and making sure that they're provided safely to patients and avoided for people who are not patients of the program. Sometimes there's issues with community partnerships. So correctional facilities may not have the expertise when it comes to treating addiction or even withdrawal. And even if they're referred to, local community providers, A, they have to be there, and B, sometimes it can be difficult to have steady help when it comes to getting them in there and also to providing follow-up care once the patient is released from incarceration. But really all of these things and other things that may have been mentioned or that you read in the literature really comes from an overarching theme of stigma. So there's a lot of misunderstanding when it comes to providing these medications. I've heard before, even in the jail that we provide these at, it's substituting one medication or one drug for another, when that's really not the case. This is really a medication that has proven benefits that can really help people. And it's really about changing the culture when it comes to approaching opiate use disorder and substance use disorders in general. Other additional regulatory barriers that have occurred. So there are several of them. Kate had mentioned, some of the logistical things when it comes to getting a buprenorphine waiver, which basically is a way for you to prescribe buprenorphine. You have to go through all these credentialing processes, which have been since reduced quite a bit, but nonetheless, they still exist. And for methadone, it's even more regulatory barriers. For example, methadone has to be dispensed through an accredited opioid treatment program or OTP. And this accreditation and regulation has to go through various entities, including the federal SAMHSA, local CARF, DEA, Board of Pharmacy. There's also the National Commission on Correctional Healthcare that has to kind of approve these things as well. So there's a lot of regulatory issues that go into just providing methadone, for example, at MDC. But despite all these barriers, I wanted to share the story of one potential solution, and that's the model that we have for jail-based MAT at Recovery Services. And really, this is a collaboration between the county, Bernalillo County, and the Metropolitan Detention Center, or MDC, and Recovery Services. So the funding initially was supported through grants provided by the county, and the program is actually housed on site at MDC. And this program, this initiative, is actually the first privately owned OTP, or opioid treatment program, in a correctional facility in the nation. And it's actually one of only 11 programs that's accredited through the National Commission on Correctional Healthcare. A little bit about the history, and there's been more history than this, but this is kind of when Recovery Services came to the table when it comes to providing methadone at the jail. There had been some cases of methadone procurement and disbursement at the jail before this, but in 2010 is when the program actually officially started, and that was with the Methadone Maintenance Treatment Program, or MMT program. And really what that means is providing methadone that's already been started in the community while somebody's in incarceration at MDC. So if somebody's already on methadone, we continue it while they're at MDC. So that program started in 2010. And then in 2017, there was a methadone induction program that started. And really what's unique about this program is that it's identifying people with untreated OUD and actually starting them de novo, newly started on methadone while they're incarcerated. So they may not have been on it before, but we're starting it there so that way they can get access to these treatments and continue them post-release. And then this past year, we started a similar thing with buprenorphine instead of methadone, where we started a buprenorphine maintenance program. So again, if somebody's on buprenorphine already, we continue their buprenorphine while they're incarcerated. And then we are in talks with the county as of now to help initiate an induction program for buprenorphine at the jail as well. So just a quick run through of what this actually looks like on the ground. There's 4 key components when it comes to this program. One of them is screening, the other is assessment, the other is providing treatment with medication and counseling, and then also coordinating reentry. So the screening component, so MDC screens all inmates for OUD when they actually come in to the facility. And if they're already on maintenance methadone therapy, we verify their dose and we enroll them in the program and we continue them on methadone. If they're not on methadone in the community, our staff can help identify patients who have opioid use disorder, opiate withdrawal, and actually offer them induction. Patients can actually self-request to be on the program through actual kiosks that are MDC as well. So they can say, hey, I want to get started on the program too. After they're identified and screened, there's an assessment portion. So it's really a multidisciplinary team of medical providers at Recovery Services. There's an intake coordinator, a nurse, counselor, physician. There's even a pharmacist on site there as well, occasionally kind of overseeing things. But it's not just Recovery Services, it's actually collaboration with our MDC partners. So there's a medical provider there that provides non-opioid use disorder treatment that we collaborate with or have been working to collaborate with. Also collaborating with the folks at MDC, so correctional officers, administrations, those kinds of things as well. And then when it comes to treatment, we provide a comprehensive treatment program, including methadone or Suboxone, as well as substance use counseling. They get 1 hour of counseling a month, as well as the medication provided daily. And then once they're ready to release, we help with reentry as well. So follow-up care is coordinated at discharge for community partners that we have collaborated with. And they're also provided harm reduction as well at discharge. So all patients receive naloxone. They actually walk out with that in hand, and they also get naloxone and Narcan training before they leave the jail. So this is kind of a program walkthrough, again, kind of broad strokes. We store the methadone in a secure location. The staff pours the medication in a secure area. A nurse transports that medication throughout MDC, so they don't come to our clinic per se. We actually take it to their cells or their pods. And there's one kind of general area where everybody's at. And then the nurse administers the medication we expect to make sure that the medication was actually consumed. And then we repeat this cycle for all the different jail pods and cells that are at MDC. So this is kind of some pictures that were taken from the Albuquerque Journal a few years ago. You can see that the staff transports the medication. There's a nursing counselor there walking with the medication in a secured vessel there. There's a picture of the patient actually consuming the methadone, and then we watch and make sure that the methadone was correctly consumed after administration of the medication. So we see about 200 to 300 patients a day. So it's not a small clinic. It's pretty large. And the medication is just dispersed daily. So there is no days off at the clinic. We give medication every day on the weekends and even on holidays. And we have a physician on site who does inductions 6 days a week. He's great, Dr. Paul Romo. He's been doing this for a very long time, and he's fantastic at his job. So what are our outcomes so far? Well, since 2017, looking at some of the data I was able to aggregate to the beginning of last year. So for that time period from 2017 to 2021, we saw about 1,400 patients. So that's about 465 patients a year for methadone maintenance. So these are people, again, that were already on methadone that we continued. And then for inductions or new starts of methadone from that same time period, we saw about a little over 2,000 patients. So that's about 700 a year. There's been some really interesting research actually done at NBC, because this is a de novo kind of thing. And a lot of it has been done through UNM. So there's been 3 studies that have come out, 2016, 2018, and 2020, and there's another one that's currently being done right now. These have been done through the Department of Economics and other people at CASA as well at UNM to look kind of what we're doing. And I won't get into the nitty gritty of that, but I'll just tell you kind of some of the key components of what those research showed. So really it showed that people who are on methadone maintenance, so continuing on it, had reduced recidivism. So they do not return back to jail. They were less likely to be rebooked when you compare it to the standard. And there was also a longer period of time between those two things. So that was really important to show. The other thing was that because of this reduced recidivism, inmates were incarcerated less days, which means that it's more cost effective to actually use methadone maintenance therapy than actually somebody staying in jail for that additional day. So the average cost a day for incarceration is about $116. But when you look at it for using MMT for that same amount of day, for that day, it's about $23. So you save a significant portion. And all this is data to help fuel expansion of these things into other jail systems across the United States, actually. One more success, we can talk about numbers all day, and that's really important, but it's important also to look at patients themselves too. This is an actual patient card for one of the patients that was started on methadone at our jail program, and he wrote me a nice little note here, and I'll just read it for you. Without all of you in this program, my success would not have been possible. I want to thank you for your efforts and dedication to really changing people's lives. I never thought I would see the day that drugs don't cross my mind anymore. I was given a second chance at the life I deserve and want you to know that I share this success with you. I couldn't have done it without you. Today, I'm not only clean from heroin, but shortly after my meth addiction followed suit. Thank you, and I love you all. You have also helped me achieve these grades in my very first driver's license. So not pictured here is actually this patient's grades. He actually went into school and got like all A's on his classes, and just really a great success story at Recovery Services. So in the future, Recovery Services, there's, like I mentioned, a study that's going on with the methadone induction data. So these are patients that are started de novo and seeing how that reduces or affects recidivism. So hopefully that paper will be coming out soon. We started our buprenorphine maintenance program. We'll be starting inductions here very shortly, hopefully. And really what I'd like to do is kind of develop these kinds of best practices and help disseminate this information to other potential programs in the United States to see how they can kind of also develop similar programs as well. And really just thinking, again, big picture stuff. It really comes down to legislation and regulation. How can we expand these things? So of course, increasing the provision and access to MAT for patients in the justice system, but also not just thinking about it here, but also how can we divert people away from incarceration, right? And get them into treatment and avoid this whole situation as well. Thinking about funding Medicaid expansion to help pay for some of these services and follow up federal and county, state dollars to do this. Again, working with community partners to help maybe smaller rural communities that don't have access to some of these bigger, larger opioid treatment programs, making sure that they can have access to these medications as well and follow up. And then just developing this kind of multidisciplinary team where we can educate each other and really start that stigma change and cultural change that really needs to occur so we can start addressing these issues. There are some key pieces. There's a 30-day session going on right now. There's only 2 things that I saw, at least, that would be somewhat related to this, just if you're interested in advocating for some of these things. There is a Senate Bill 83 that's out right now, which essentially will allow nurses at these opioid treatment programs to dispense methadone without supervision of a pharmacist. So sometimes that can help if the pharmacist is a significant cost burden to some of these programs, allowing the nurses to do that. And it's been proven to be safe as well. There's a Harm Reduction Act bill that's also there to help provision of supplies and devices for harm reduction programs. There was a bill last session that was specifically targeted to help expand treatment of these things at the jail, but it died in that session. But I've heard rumors that something very similar will be bubbling up on the next session, 60-day session as well. So yeah, these are some references, and that's my story. Thank you.
Thank you so much, Sergio. That was really informative, and I think gives a lot of people much hope. Our next guest today for this extraordinarily informative session is Daniel Rowan, who's the co-founder and executive board member for Best Chance, an organization that's dedicated to serving the diverse needs of recently released prison inmates. Daniel currently works as a program manager for the New Mexico Peer Education Project at Project ECHO, which trains incarcerated men and women to be peer health educators. Daniel holds unique insight and compassion for the incarcerated, as well as for the returning citizen community, as he himself has been incarcerated multiple times and where he struggled with substance use. Daniel utilizes these unique experiences to guide his work in the communities he serves, and he personalizes his approaches. We're very thankful to have you so much, Daniel.
Yes, thank you. And give me just a minute. I'm going to get my slides up. And I trust everyone can see that where it says the New Mexico Peer Education Programs. All right, sounds good. I'm just gonna get. Okay, so yes, thank you. It's an honor to be here today. I appreciate being able to speak on this panel with such esteemed folks that came before me. I'm going to talk about some programs that we have at Project ECHO that we operate in the prisons and in the community. So I'm going to jump into it. So I'm going to be going through 2 different programs very quickly, one of which occurs in the prison and one of which occurs in the community across the state of New Mexico. And I just think that it's important that I start off from the very beginning and how these projects came into existence, which really all started with our director, Dr. Carla Thornton, when 10 years ago, utilizing the ECHO model, she began training medical providers in the prisons. And so all of these stars are prisons in the state of New Mexico. And she was training the medical providers to treat hepatitis C. And so interestingly, substance use disorder, hepatitis C are actually very closely linked. If we had more time, we would talk about all the reasons why it's important to treat people with hepatitis C, but I'll save that for another day. So as Dr. Thornton was treating hepatitis C, she realized that there wasn't a lot of consistent hepatitis C education happening. And so she wanted people to know what was happening. Why do you need treatment? And how can you prevent reinfection? And so she addressed this through education and really found a low cost and effective way to take education, really vital and critical education, to a disenfranchised population. And that was through peer education. And so why peer education in the prison? Why do this work in the prisons? And so our why is that we believe that redemption is the solution, and that time spent incarcerated should be an opportunity to really regain a healthier and a more productive life. Which I would add that offering people the treatments that they need for substance use disorders fits quite nicely right within that why. And concerning our folks who are returning citizens, we really believe that supporting them to become more accountable, interdependent, and goal-driven is really essential to building and creating healthier communities. So I'm going to get started with our program in the prison. There are 4 components to this program. I'm going to run very quickly through them. I like to say, I hope everybody has their shoes tied tightly because we are going to run very quickly. But the first question, how do you get peer educators in the prison? How does that happen? And it's very simply, it's an in-person, face-to-face training where those of us from the hub team go into the prison and we train a selected group of inmates, 15 men or women, depending on the prison, on a whole host of health-related topics. And while the program was developed to address the problem of hepatitis C, being that over 50% of those upon entry to the prisons test reactive for hepatitis C antibodies, it would be very difficult to address hepatitis C without also addressing addiction or substance use disorder. You can see there's a number of different topics here. I won't get into all of them. I just want to emphasize here that the peer educators do learn about addiction, substance use disorder. We actually train on the evolution of the terms. We do our best to keep up with them as how we've moved into substance use disorder. But we also train on the brain. And so we train on the neurology of addiction so that people understand what's happening inside of the brain and what's happening with dopamine. And then we lead exploratory activities where people, where the peer educators and then the participants are able to explore why it is that we use, why do we not use, why do we relapse, and how do we recover. And so all of that is trained. These are all topics that the peer educators learn. And I appreciate that the risk of overdose was already mentioned because we do also have that included in our curriculum because people who are incarcerated coming out of incarceration are at that 10 to 40 times higher risk of overdose. And I've even seen statistics of 70 times higher. So the question is, we're training the peer educators, they're learning about all these topics, but how do they get that information that we give them to their peers, or how do we get the water to the plant? And we do that by equipping our peer educators with training tools. And so our peer educators are trained on the stages of change, basic motivational interviewing, and adult learning theories so that the workshops are fun, interactive, and engaging. The best opportunities for adults to learn in. They also are trained on public speaking and even Aristotle's rhetoric. They learn how to package stories in a really impactful way. We have a saying in peer education that if you teach to the heart, the mind will follow. And our peer educators really have become masters at their craft to where they can tell stories that are impactful and people remember them. And it really is learning opportunities for the people that they're teaching. But they also learn conflict resolution, workshop facilitation, team building. A really big concept that we promote is that leaders build other leaders, that we support. We're here to support and lift each other up. And another one that's really important is that community plus service equals purpose. And that's the real opportunity that being a peer educator in prison is that you get to be a part of a different type of community. You have the opportunity to be of service and you discover a new purpose. And there's something that's really special about purpose. And if you look in this picture, I would like to point out one thing, and that's that all the men in this picture are smiling. And I can't think of a better way to capture what happens when you empower individuals with a new purpose, is it puts a smile on your face. So at the end of their training, where we have created an opportunity of learning and engagement, they then have the opportunity to do the exact same thing for their peers, because it's now their responsibility really to carry the program forward and to train their peers on all those topics. And they do that through 10-hour workshops. Here I have a nice candid shot of them getting ready to play Health Jeopardy, their adult learning theory in action, all the really just amazing handmade posters that these guys and gals make. And really the peer educators just do an excellent job of educating their peers. The data that we've collected with pre and post test knowledge tests has shown it over and over again that there's a consistent knowledge increase with these workshops. We do provide continuing support for the peer educators utilizing our ECHO model, and that we do something pretty unique. We bring all of the peer educator sites together, all of the prisons, men and women, we come together. We do case-based learning. We work collaboratively to develop best practices in these ECHO sessions, and they do get continuing education units for UNM. But on a larger level, what's interesting that has happened is that it's created a community across the peer educators where it's no longer about one peer educator or one prison facility. It's about all of us working towards this goal of creating healthier prisons, which I know to some people might sound crazy. It's a daunting task, but it's what we're working towards. It's healthier prisons. We also provide regular follow-up for the peer educators. That includes in person, where we deliver some of the needed supplies, do some team building, and it's an opportunity to work with the wardens and unit managers. COVID-19 has been a challenge, and so like much of everything over the last couple of years, we have had to also do a lot of those site visits virtually. We are very thankful for the infrastructure that we've had in place with the ECHO model. Because of that, we were able to continue to meet with prison facilities and really sustain the project through the pandemic. We are just now getting back out into the prisons and doing in-person trainings again, slowly and cautiously, which we're grateful to get back out there and do those. Real quickly, I just wanted to talk about the reach of the peer educators. This next slide is a little busy, but I just want to focus on that number. We're almost at 16,000 people that the peer educators have educated within the system, within the prisons during the life of this project. And so really, the peer educators have done just an incredible job of educating people. And you can see by the numbers. And the peer educators have actually done such an incredible job that it's really created a really healthy working relationship with the New Mexico Corrections Department. The relationship is actually such a good relationship that Probation and Parole Department approached us just a couple of years ago. And they said that they wanted to provide support for their clients. They actually wanted to have a non-punitive program that provides support to the men and women who are on probation and parole. And so I was surprised to hear this coming from Probation and Parole, a non-punitive program of support, but also very grateful for the opportunity for us to develop that program. And so in the middle of a pandemic, we developed a 100% virtual peer support program. And what I love about this program, this community peer education project, is that we have taken our formerly incarcerated peer educators who have successfully transitioned back into the society. And we have taken them through another training, and now we employ them as peers. So they actually provide virtual peer support to men and women across the entire state. And they also provide virtual peer groups on a weekly basis. And with this being ECHO, we do support them utilizing the ECHO model, case-based learning and developing best practices. And so it's a real honor today to introduce everybody to our peer team, our team of community peers former peer educators. The graph to the side, you see that the green, that's the portion of their job that is peer support. So they do a lot of engagement, making sure that folks get resource referrals, but they also do a lot of encouraging, a lot of sharing their own personal stories, their own personal struggles, and offering a window of hope for the folks who are still on supervision. And that's the one thing that I'll say, or one of the things that I'll say about peers is that peers have the ability to encourage resilience because they've been where the people that they're talking to are, or at least have been through similar experiences. They also provide, really offer a window of hope as they share their own personal stories of recovery. And as peers, we share our struggle and even walk together as we overcome and transform our lives and moving past incarceration. Our referral process is pretty simple. We take direct referrals from probation and parole. Interestingly, we pulled the data of how many people are referred for substance use support, and currently about 33% of all referrals are people looking for substance use support. Of course, this number is not representative of the total number of people on supervision that potentially are already receiving that service or need it. That's just how many referrals we're getting for that. This program was also specifically developed to target high risk, high need individuals. And so we believe that's why the top resource requests are those four things: employment, housing, vital documents, and substance use support. And this one of these last slides here, I just like to reiterate this: community plus service equals purpose. I was introduced to the program during my own incarceration. My colleague, Carissa McGee, who's standing at the front teaching, she was also introduced to the project during her own incarceration. And there we are. There she is teaching at the facility. She was literally there. She is literally a person who has been where they have been. And what's interesting is we led this entire training with no staff in the room whatsoever, 2 formerly incarcerated people in a room full of incarcerated women, training on the topic of interpersonal violence. And so I can't think of a better picture to demonstrate really, that purpose does connect you to something greater than yourself. And when you learn that you have a voice, that you want to contribute. And that's what that's what our peers really want to do, is they want to contribute to healthier prisons and healthier communities. And the other byproduct of being a peer is that you learn to be an advocate for yourself. And so maybe you do need medication assisted treatment or something like that. You learn to have the voice to go out and be able to advocate for what you specifically need. So we like to say that what we do is we support our communities by investing directly into returning citizens and investing directly into women and men who are incarcerated. There's a saying out of Just Health that those closest to the problem are often farthest from the power and the resources to do anything about it. And this program is feeding resources directly to those who have been impacted, who have been typically disenfranchised, so that they can work towards the solution. I end with these last 3 words: innovative, peer-led, and life-changing. And just for everybody who's involved in substance use disorder treatment, I hope that all of us are thinking of ways that we can be innovative in our approaches, that we're looking at ways that we can incorporate peers so that we can create that lasting life change.
Oh, so powerful, all of these presentations. I want to thank all of our panelists. We are at the top of the hour, and I know we're going to be losing many of you. Some of us are happy to stay on and entertain any questions, but I don't know if our panelists can stay on for another 5 minutes or so. It just gives us so much hope and so much to look forward to. And I hope everyone here heard that, you know, regardless of where you come from and what you do and what your profession is, you can make a little difference. And that's how this is really happening. I feel really fortunate to be here. We can take some questions in the chat. There's a lot of wonderful notes in there from people telling you about your presentations that were so good. Please raise your hand or wave if you want to ask a question. We will be asking our panelists if we can share their slides. Valerie Kling Grant County has a question.
Hi. Yeah, I'm sorry, my camera's off. I've been having internet troubles today. My name is Valerie Kling. I work in Grant County. I'm the Grant County coordinator for the YSAP program. I had a question because I've been looking into peer support workers and how that could help with our community. This might be a silly question, but specifically maybe geared towards Daniel. Do you have to have a past of like being incarcerated or drug use, stuff like that in order to be a peer support worker? Or can you have sort of like an understanding through people maybe in your circle, like your family members, stuff like that?
Yeah, that's a great question. So like for our specific program, of course, we are looking for people that have incarceration in the background, but to be a certified peer support worker in the state of New Mexico, it's really just, it could be an experience with trauma, it could be experience with mental health, it could be substance use, it could be a whole host of issues. If it was a family member who's experienced that, who's had family members that experienced those problems, there is something that's called a family peer support specialist that is specific to that. And you can get more information for that through OPRI, the Office of Peer Recovery and Engagement. Oh, somebody beat me to it. Maria got it in there. Awesome.
Yeah, okay, awesome. Thank you so much.
I'm really glad that we have some of the peer support groups here. I see Carissa and many others that were in the photos. Really terrific. Any other questions? Wave, unmute yourself, jump in. And if not, we will be asking our panelists and try to put their slides up on our website. And if you have questions, we'll put their contact. We'll make sure that there's a way to send more questions to everyone. If there's no more, we can adjourn and you can all take your day back. Thank you so much for attending this Southwest Clinical Trials Network panel. We will be offering another one in a month or two about a fentanyl update. Lots of news about fentanyl, lots. And we hope that you'll join us again. And Christina and Anne Marie and Catherine will all be helping to make sure that that gets well publicized. We thank you all so much for your support.